Transabdominal amnio-infusion, including ultrasound guidance. The physician infuses an abnormally underhydrated amniotic sac with fluid. This may be done as a prophylactic measure for the fetus or to enhance sonographic imaging. An amniocentesis needle is placed through the mother's abdomen and advanced between extremities of the fetus under separately reportable ultrasound guidance. Normal sterile saline is infused into the uterus until the fetal anatomy is adequately visualized. The needle is removed and a detailed ultrasound is carried out. Transabdominal amnio-infusion procedures may also be conducted prior to invasive procedures, e.g., fetoscopy and fetal shunts, to allow placement of instruments. Fetal umbilical cord occlusion, including ultrasound guidance. Fetal umbilical cord occlusion is carried out in cases of complicated monochorionic multiple gestation pregnancies or in cases to terminate a pregnancy due to a birth defect. Ultrasound is used to locate access to the umbilical cord, avoiding the placenta. Using ultrasound guidance, small forceps are advanced into the uterus and the cord of the affected fetus is identified and grasped. The umbilical cord may be ligated, occluded, or compressed. Complete absence of flow through the cord is confirmed and the instruments are removed. Fetal fluid drainage, e.g., vesicocentesis, thoracentesis, paracentesis, including ultrasound guidance. Fetal fluid drainage is done in cases of pleural effusions or pulmonary cysts, and especially in fetal megavesica, a rare syndrome caused by functional obstruction of the fetal urethra. The fetus bladder is enlarged. Oligohydramnios, dilation of the lower and upper urinary tract, and hydronephrosis may also be present. Pulmonary hypoplasia can result from this and lead to hypoplastic abdominal musculature, urinary tract anomalies, and cryptorchidism. The fetal urinary bladder is emptied by transabdominal intrauterine vesicocentesis. Under continual ultrasound guidance, a 20 to 22 gauge needle is inserted through the mother's abdomen and advanced into the fetus bladder. Fetal urine is aspirated and sent to the lab for analysis of urinary electrolytes and to determine renal function. The needle is removed and the patient kept for monitoring for up to another hour to check for refilling in the bladder. Fetal shunt placement, including ultrasound guidance. Fetal shunt placement is performed for pleural or vesical amniotic shunting in cases of pleural effusion, pulmonary cysts, or fetal megavesica, where the bladder is enlarged because of urethra blockage. Shunting is done to supply continuous drainage when reaccumulation of fluid is not successfully treated by isolated vesicocentesis or thoracentesis. Fluids can be drained into the amniotic cavity through a double pigtailed catheter. The entry site on the mother's abdomen is cleaned with antiseptic solution and local anesthetic is infiltrated down to the myometrium. Under ultrasound guidance, a metal cannula with a trocar is introduced transabdominally into the amniotic cavity and inserted through the fetal chest wall in the mid-thoracic region, into the effusion or cyst. The trocar is removed and the catheter is inserted into the cannula. A short introducer rod is used to place the proximal half of the catheter into the effusion or cyst. The cannula is gradually removed into the amniotic cavity where the other half of the catheter is pushed by a longer introducer. There is now a conduit for fluid drainage into the amniotic space. Placement of the shunt is confirmed, the instruments are removed, and the patient is monitored for 1 to 2 hours. Follow-up ultrasound scans are performed at weekly intervals to check drainage and determine if the effusions reaccumulate, in which case another shunt may be inserted. The drains are immediately clamped and removed after delivery.